This video is about critical appraisal of literature on prognosis. The basic outline is the same as that of appraisal of articles on harm. You still have relevance, validity, results, applicability, and the resolution. Why study prognosis, or why do we need the prognosis of diseases as clinicians? Prognosis informs our decisions on whether to treat or not. If a patient is likely to improve without intervention, clinicians should not recommend treatments, particularly those that are expensive or potentially toxic. On the other hand, some patients will experience poor outcomes regardless of which treatment is given. By understanding prognosis and presenting the expected future course of a patient's illness, clinicians can offer either reassurance and hope or preparation for long-term disability or death. Let's start with the appraisal. Again, first is relevance. Is or are the objectives of the article relevant to your clinical dilemma? The formulated clinical question must be addressed by the objective of the study. The objective of the study must clearly state that it is determining the prognosis of patients with a prognostic factor among patients with a disease being studied. Compare the PICOM format of the clinical scenario with the PICOM format of the retrieved journal article. Are the PICOM formats similar? You compare the PICOM of your clinical scenario with that of the journal article. The methodology for prognosis should be cohort studies or case control studies. That is for primary studies. But if there are systematic reviews or meta-analysis, then you should look at those first. The validity guides for prognosis are different from those for harm. There are still 5 questions. We will go through them one by one. First is, was there a representative group of patients without the outcome at the start of the observation? Ideally, patients representing the complete spectrum of the disease must be included in the study. Examine the inclusion-exclusion criteria of the subjects to ensure elimination of selection bias. Determine whether patients pass through some sort of filter before entering the study. For example, patients who are recruited from tertiary hospitals are often more severe or have more complicated comorbidities. If all the patients are recruited from a tertiary hospital alone, then your prognosis results would be skewed towards a worse prognosis. The second validity guide is, was follow-up sufficiently long and complete? The length of follow-up must be sufficiently long enough to detect the outcome. In prospective studies, the acceptable dropout rate is less than 20%. In retrospective studies, the acceptable non-response rate is also less than 20%. Intention to treat analysis or worst-case scenario analysis may also be done. Third question, were the criteria for determining the prognostic factor and outcome explicit and credible? Outcome criteria should be objective and unbiased. Examples of outcomes are mortality versus survival, symptom progression, or recurrence of disease. Fourth question, was there adjustment for other prognostic factors? Most confounding variables such as age and sex can affect prognosis. Hence, they should be addressed or adjusted through subgroup analysis, multivariate analysis, or regression analysis. Regression analysis allows us to determine the most powerful predictors or prognostic factors. Overall, is the study valid? Ideally, all answers to the previous 4 validity guides should be a yes in order for the study to be valid. For the results, we look at the RR for cohort studies or OR for case control studies. RR or OR greater than 1 means the prognostic factor is positively related with the outcome. Results from studies of prognosis or risk may also often be reported as the proportion or percentage of patients with a certain outcome, such as death, inability to walk, dependence on dialysis, etc. After a certain period of time elapses, for example, 28 days, 3 months, 12 months, 5 years. The survival curve is another way to depict the results. It is a graph of the number of events over time. The events must be categorized as dichotomous variables, yes or no, such as death, stroke, recurrence of cancer. And investigators must know the time at which the events occur. In the survival curve shown, the outcome is survival after a myocardial infarction compared between a treatment group and control group. After 2 years, around 85% survive in the treatment group versus around 80% in the control group. Was the result statistically significant? Again, the p-value should be less than 0.05, and the 95% confidence interval should not cross 1.0. For the applicability, are the study patients similar to your patient in the given clinical scenario? The characteristics of the patient must be similar to the study's inclusion and exclusion criteria. Examine also the socio-demographic profile of the study subjects. Can I use the results to decide on the intervention or reassure my patient in the given clinical scenario? Prognostic data should be used in decisions about therapy. Knowing the probability of the outcome based on the prognostic factors present in the patient should influence the decision to give or withhold treatment. Also, prognostic data may be helpful in reassuring anxious patients. For the resolution of the problem or conclusion, based on the appraisal of the given set of data, what conclusions may be drawn? Use this to resolve the given clinical dilemma and apply it in clinical practice. And that's the end of the appraisal for an article on prognosis. Again, I just want to emphasize the difference in the validity guides of harm and prognosis, as you can see here. These are my references. For you to better understand these concepts, please answer the exercises on your manual regarding appraising an article on harm and prognosis on pages 88 to 96. See you at our live Q&A.